Hello everybody. Welcome to Number 1 Doctor channel. Today video is about ophthalmology diseases, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel Number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about ophthalmology diseases. Children. Amblyopia is a vision impairment resulting from interference with the processing of images by the brain during the first 6 or 7 years of life. The most common expression of this phenomenon is the child with strabismus. Faced with two overlapping images, the brain suppresses one of them. If the strabismus is not corrected early on, there will be permanent cortical blindness of the suppressed eye, even though the eye is perfectly normal. Should an obstacle impede vision in one eye during those early years, for instance, a congenital cataract, the same problem will develop. Strabismus is verified by showing that the reflection from a light comes from different areas of the cornea in each eye. Strabismus should be surgically corrected when diagnosed to prevent the development of amblyopia. When reliable parents relate that a child did not have strabismus in the early years but develops it later in infancy, the problem is an exaggerated convergence caused by refraction difficulties. In that case, corrective glasses instantly resolve the problem. True strabismus does not resolve spontaneously. A white pupil in a baby leukocoria is an ophthalmologic emergency, as it may be caused by a retinoblastoma. Even if the white pupil is caused by a less lethal problem, like a congenital cataract, it should be attended to in order to prevent amblyopia. Adults' glaucoma is a very common source of blindness, but because of its silent nature, it is unlikely to be discovered by regular physicians or to be tested for in an exam. One variant, however, should be recognized by every physician who might encounter it. Acute angle closure glaucoma shows up as very severe eye pain or frontal headache, typically starting in the evening when the pupils have been dilated for several hours watching a double feature at the movies, or watching TV in a dark room. The patient, often a female of Asian extraction, may report seeing halos around lights. On physical exam, the pupil is mid-dilated and does not react to light, the cornea is cloudy with a greenish hue, and the eye feels hard as a rock. Emergency treatment is required. Ophthalmologists will drill a hole in the iris with a laser beam to provide a drainage route for the fluid that is trapped in the anterior chamber. While waiting for the ophthalmologist, administer systemic carbonic anhydrase inhibitors such as Diamox and apply topical beta blockers and alpha-2 selective adrenergic agonists. Mannitol and pilocarpine may also be used. Orbital cellulitis is another ophthalmologic emergency. The eyelids are hot, tender, red, and swollen, and the patient is febrile, but the key finding when the eyelids are pried open is that the pupil is dilated and fixed, and the eye has very limited motion. There is pus in the orbit, and emergency CT scan and drainage have to be done. Chemical burns of the eye require massive irrigation, like their counterparts elsewhere in the body. Irrigation with plain water has to be started as soon as possible wherever the injury happened. It cannot wait until arrival at the hospital. Once the eye has been pried open and washed under running water for about half an hour, transportation to the ER should be arranged. At the hospital, irrigation with saline is continued, corrosive particles are removed from hidden corners, and before the patient is sent home, pH is tested to assure that no harmful chemicals remain in the conjunctival sac. As is true elsewhere in the body, alkaline burns are worse than acid burns. Retinal detachment is another emergency that should be recognized by all physicians. The patient reports seeing flashes of light and having floaters in the eye. The number of floaters gives a rough idea of the magnitude of the problem. The individual with 1 or 2 floaters may only have vitreous tugging at the retina, with little actual detachment. The person who describes dozens of floaters, or a snowstorm within the eye, or a big dark cloud at the top of his visual field has a big horseshoe piece of the retina pulled away and is at risk of ripping out the rest. Emergency intervention, with laser spot welding, will protect the remaining retina. Embolic occlusion of the retinal artery is also an emergency, although little can be done about it. The patient, typically elderly, describes sudden loss of vision from one eye. In about 30 minutes the damage will be irreversible, but the standard recommendation is for the patient to breathe into a paper bag and have someone repeatedly press hard on the eye and release while he is in transit to the ER. The idea is to vasodilate and shake the clot into a more distal location, so that a smaller area is ischemic. Newly diagnosed diabetics need ophthalmologic evaluation if they have type 2, because they may have had it for years before diagnosis was made. Retinal damage may have already occurred, and proper treatment with the use of lasers may prevent its progression. Youngsters diagnosed with type 1 are about 20 years away from getting eye problems. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.